Okay, welcome. It's Monday afternoon, and welcome to Mount Sinai Beth Israel Department of Medicine Grand Rounds. We are very excited to have Dr. Satish Nagula join us today. Dr. Nagula attended college at the University of Virginia and went to medical school at Yale. He completed internal medicine residency training at the University of Pennsylvania and went to GI fellowship at Memorial Sloan Kettering Cancer Center. Which brought us here locally to New York City. There he received niche training in the endoscopic management of GI malignancies. And further, he worked at Stony Brook on Long Island for several years, serving as the director for endoscopy and the director of the second year GI pathophysiology course. He joined Mount Sinai in 2015 with a clinical focus in advanced endoscopy, endoscopic oncology, and pancreaticobiliary diseases. He has a fond passion for teaching and serves as the PD of the GI Fellowship at the Icahn School of Medicine, Mount Sinai Hospital. Welcome, Dr. Nagula.
Thank you. Thanks for the invitation today. I really appreciate it. I'm going to go ahead and share my screen as any good modern day Grand Rounds evolves. It's a real honor to be able to share a topic with you today that is a real passion of mine. It's really what brought me into GI to begin with. I wrote my personal statement at GI Fellowship about Barrett's esophagus and endoluminal stent placement. And so I've been real fortunate to sort of stay on that path ever since. And it's really comprises the bulk of what I do today. So my talk today is entitled New Frontiers in Advanced Endoscopy. For quite the longest time, the world of advanced endoscopy was a little static, a little bit sort of focused on either taking out stones during ERCP or biopsying masses through endoscopic ultrasound. And now over the last, I would say, several years, the types of interventions we're able to offer has really exploded through a combination of innovation in technology and just sort of thinking out of the box. And so with that, my disclosures. And as I mentioned, we've got our core procedures in endoscopy, upper endoscopy and colonoscopy, which, as we all know, is the bread and butter of what we do. And then somewhere probably in the 70s or 80s, ERCP was developed, and this allowed us access to the bile duct and the biliary tree, and is the mainstay for what we do to manage bile duct stones and manage strictures of the bile duct. Eventually came endoscopic ultrasound. So at the very tip of the scope, we have an ultrasound probe. And what that lets us do is look through the lumen of whatever organ we're in. If we're in the small intestine, if we're in the stomach or in the rectum, you can see what's around you. So now the world of endoscopy is expanded to beyond what you see in front of you to go to what you see transluminally in the tissues adjacent to you. And if those are our core procedures, this has allowed us to open up a whole world of different techniques: endoscopic mucosal resection to remove tumors, anti-reflux therapies for the management of gastroesophageal reflux, ERCPs for complex stone extraction and stent placement. We have techniques for fine needle aspiration and biopsy. We're now able to get core biopsies of any number of different tumors, pancreas, liver, lesions in the mediastinum, lesions in the rectum. We can drain collections within the abdomen, abscesses, gallbladders, pseudocysts. We have the ability to ablate tumors using needle probes through EUS and able to actually burn tumors and deliver an oncologic outcome. Pseudocyst drainage and necrosectomy. We can do injections into tumors and placement of fiducials. There's a whole world of endobariatrics, and there are actually a whole world of bariatric weight loss procedures that can be performed all through the endoscope. There's an exciting world of endosurgery, third space endoscopy. We're able to tunnel inside the layers of the intestinal wall to remove tumors. Barrett's ablations, removal of esophageal cancers with endoscopic resection, and stent placement for the management of luminal obstruction. We could spend a whole weekend course talking about the full breadth of things here. I'm going to talk about three areas of particular interest and particular excitement to me, and things that have potential to change the way you think about some of these diseases as internists. And that's going to be EUS-guided drainage, pseudocyst drainage and necrosectomy, and endoluminal stent placement. So we'll start with the management of malignant GI obstruction. And as I mentioned, this has been a long-standing passion of mine and one of my first entries into GI. So if we wind back the clock to 2005, I was a second-year resident at the time. And we had the Oprah Winfrey approach to stents. You get a stent, you get a stent, you get a stent, everybody gets a stent. That's how we approached every obstructed lumen in the GI tract. If you had an obstructed colon, you got a stent, an obstructed duodenum, you got a stent, and it was stents for everybody, stents at all times. I would say we got a little wiser since 2005, but it took us kind of a while. We were pretty excited to have that technology, and we really stented a lot of things. So what are these stents? There's a world of what we call self-expanding metal stents. They have a catheter sort of like this. There's all sorts of different brands, and this stent is actually elongated and stretched onto this catheter. And so a little video of what it looks like. Here's the catheter here. That video is not working. Well, you can sort of see that the stent here expands as we pull the sheath out of the catheter, or pull the sheath back along the catheter. So that stent will expand open, push against a tumor, and allow GI luminal contents to pass. So a little animation of what stent placement is like. This is a stent catheter going across the tumor. Here is a colon cancer. As we pull back the sheath, the stent expands and pushes the tumor out of the way and allows for stool and contents to pass through. This same premise is what's used for pretty much all stents in the GI tract. So with that in mind, we'll start about esophageal obstruction. Here's a patient with a squamous cell carcinoma of the esophagus. And here's a esophagram where you can see the lumen of the esophagus is really very narrowed right in the middle. And then after stent placement, here is a stent on X-ray, and you can see that now there's a wide open lumen there. Contrast passes through very easily. So when we think about different ways to approach malignant dysphagia, right, obstruction of the esophagus from cancer, dilations, they work really well, but they work for a week. We inflate a balloon into the tumor, push the tumor open. As soon as you take that balloon out, it's a cancer. It's a tumor. It's going to just roll right back into place. It's like pushing aside sand at the beach. Different techniques of burning, APC, photodynamic therapy. Because they're burning away the tumor, we do get some duration of relief, but it's not great. Stent placement, you get great relief of dysphagia. It can last 5-6 months. Actual treatment of the tumor, chemoradiation, you might get 6 months or even more, depending on the tumor and depending on the regimen. So the way we think about it is we offer patients multimodality palliation if they're unresectable. Patient has metastatic disease, they're unable to swallow. They're able to swallow maybe liquids only. So then that's someone who might really benefit from a stent. So we place a stent right away that allows them to build up the nutritional status. Then they go on to get chemotherapy for their advanced disease. And patients with resectable disease, so patients with relatively early stage esophageal cancer, recent studies have suggested that stent placement leads to poor long-term outcomes. It's a little bit unclear as to why, but there has been some data to suggest maybe in those resectable patients, if you can just get them through long enough with either like full liquid diet, even feeding tube placement, that might be preferred. Stent placement, again, we used to place them in everybody. When we started to learn that stent placement hurts. As that stent expands open, you're pushing against a fixed space in the mediastinum, and that could be rather painful. Most of the time, this pain gets better within the next couple of days, but some patients, it's more persistent than that. So it's something I really caution my patients about. And in patients who don't want to eat, a stent's not going to help them eat. They're either too sick or too ill or too weak. They need a PEG. And PEG tubes have sort of a bad reputation, but PEG tubes are really great for supporting someone's nutritional status when it is indicated. The issue is the indication for PEG placement, not the procedure itself. So, and a patient who's just got poor oral intake, but still has the vibrancy and desire to continue to live and interact with those around them, PEG is a great way to maintain nutritional status. Not something I would recommend in the hospice scenario or terminal situations, but in really good candidates, PEG placement is an incredible benefit, and it takes a lot of pressure off the patient and the family. There's so much pressure placed on patients to eat, but if they can't or just don't feel like it, it's a lot of stress. And so if you're able to nourish them via PEG, that's a huge benefit. So overall with stent placement, it's a little bit of a balanced approach to this. With a stent in place, they can eat soft diet, like a soft diet. So like pasta, eggs, fish, rice, things like that work very well. And we only really think about stent placement once they're unable to tolerate full liquids. If they can get Ensure and Boost and then go get chemo radiation for their tumor, that's perfectly fine. It's once they fail full liquids that you really need to start thinking about stent placement. Gastric outlet obstruction. So gastric outlet obstruction, as the diagram depicts here, this is obstruction of either the duodenum or maybe the pylorus, most classically from gastric cancer or duodenal cancer or pancreatic cancer. And so we see this a reasonable amount. First things first, survival in gastric outlet obstruction is quite poor. In a retrospective series several years ago, 50% of the patients died in 12 weeks. So once you have an advanced malignancy that's causing duodenal obstruction, there's a high rate of mortality in those patients. So it's important to sort of recognize that. How do you palliate gastric outlet obstruction? So you can do a venting gastrostomy. So that's literally a peg tube into the stomach, but instead of using it to feed, you can open up the tube and let it drain into a bag. This allows for sort of an on-demand relief of obstruction. So if they feel full or they're going to vomit, they can open the tube and relieve that. A duodenal stent, so that is that self-expanding stent here in the duodenum, or a gastrojejunostomy. So this is a procedure where you literally take some of the jejunum here and attach it up to the back wall of the stomach. And this allows for food and nutrients to pass through right directly into the small intestine. So at least in thinking of surgical gastrojejunostomy and stent placement, all are reasonably effective at decreasing nausea vomiting scores and also improving the eating restriction. They allow patients to get back to a pretty regular diet, actually. If we think of survival in the stent versus the gastrojejunostomy group, and again, this is a surgical group here, the clinical success, not survival, just parameters, the clinical success here is really good. 90% in the stent group, 70+% in the gastrojejunostomy group. There are pretty similar amount of complications. In the stent group, the complications take the form of stent migration or stent occlusion. If that occurs, we just place a new stent in there. In the surgical group, if you end up with major complications, these are much more significant, have a lot more morbidity, a leak at the anastomosis, dysfunction of the gastrojejunostomy that never ends up opening up. And so although we count them both as major complications, the ones in the surgical group are a bit harder to sort of manage. Minor complications, certainly more in the surgical group, wound infections and so on. These are fairly sick patients, as I mentioned. And the mean hospital stays are certainly longer in the surgical group. After stent placement, patients are able to go home relatively quickly. Many of these patients are sicker, so they're in-house for a little bit longer, but they're generally able to resume oral intake within a couple of days and are usually able to get right up to a regular diet. Now, there was an interesting study done a handful of years ago that got us really thinking about, is it really stent for everybody? Or do we have to think of this a little bit differently? And so this is a study that looked at sort of patency rates, and it's essentially a survival curve. The patency rate of the gastrojejunostomy in the first 6 months is actually fairly similar to the stent group. But what about the patients that live longer? This is a study of patients with gastric cancer, which is a little bit different from pancreas cancer, where those patients tend to die very quickly. As you go out a little bit longer, you start to see that the surgical group has a much higher patency than the stent group over here on the left. And so those patients, even though in this dotted line here, these are stent groups, the stent patients, and if they have an issue with patency, they get restented. And even after they're restented, the patency is never as great as a surgical group when you get to those patients who live beyond 6 months. Well, how does this correspond to survival? Well, if you look at patients with really good functional status, the patients with a gastrojejunostomy actually have far better survival than patients who got a stent. In patients with lower functional status, the curves look much more similar. So how do we think about this then going forward? In patients who got a long survival, they're going to outlive their stent. And if that stent closes or occludes, that might lead to a hospitalization, an aspiration, a pneumonia, and that is going to hurt their survival. If you've got a younger patient with an early gastric cancer, they might do better with surgery because you will keep their patency longer. It'll be good for them in the long term. We have patients with other semi-indolent tumors like pseudomyxoma peritoni. I had a patient with cervical cancer recently who had a lot of options ahead of them. Those patients do much better with surgery. Patients with more advanced disease, pancreatic cancer generally is very advanced when it causes duodenal obstruction. Duodenal cancer is very advanced. Or people with widely metastatic disease, they might benefit from stents. So there have been some advances in how we think about stenting on gastric outlet obstruction. The other stents I showed you were these long stents that are like long springs. There is a novel stent design called the lumen opposing metal stent, a LAMS. It is a short stent. It's only 1 centimeter long, and it has these butterfly-like flanges. The intention of this thing is to take 2 lumens, stick them together. So in this little animation of a drainage of a gallbladder, which we'll talk about later, here is a tip of our scope. And with ultrasound, we drive a catheter across the duodenum right into the gallbladder. And then we deploy one of these LAMs, one butterfly flange here, and another one here. Now we've effectively connected the 2 lumens. So once we dilate up the tract and take our catheters out, you've now created a fistula between the gallbladder and the duodenum. This allows the gallbladder to drain completely. So what if you use this to create an EUS-guided gastrojejunectomy? Here's a little diagram. Mind you, this is an off-label use of this technology, but it is gaining enormous traction in the endoscopic world. Here is the stomach here. And then what we can do is place this stent across the stomach wall into an adjacent loop of jejunum. And then you deploy the stent, now creating a connection between the stomach and the jejunum, or essentially a gastrojejunectomy. So here's a quick video that shows this. So this is on EUS. It's black and white. It's always a little grainy. Here's the jejunum here. Here's our scope, and this is the needle. This is us injecting contrast into the jejunum so that it's nice and full, gives us a target to aim for. This is the catheter right here. And we're going to go right across the stomach wall. Here's the stomach wall here. Here's the jejunal wall here. We're going to go right across there and deploy the stent. Here is one end of the stent. That's me pulling the jejunum all the way up to the stomach wall. And now in this endoscopic view, I'm in the stomach right now. We're in the stomach right now. And we're deploying the stomach side of the stent. So here's the stent here. This is the stomach. This stent is going across the stomach wall directly into the jejunum. So we've made our own hole through the stomach and jejunum. We're going to open up the tract a little bit. And what you see on the end of the side, this is a piece of jejunum on the other side. This is an endoscopic gastrojejunectomy. This was performed by one of my colleagues, Chris DeMeo. This procedure probably took about 30 minutes to do. And the patient was able to resume eating essentially the next day. So the clinic, although this has gained enormous excitement in the endoscopic world, my caveat and caution is the data is still limited to cohort studies, retrospective case control studies. There are no currently published RCTs, although there's some, I believe, ongoing looking at these. The retrospective studies, similar clinical success as duodenal stents, over 95% success rate. Lower rates of reintervention. So the gastrojejunectomy patients have a 4% rate of reintervention versus the stent group. Much higher rate of reintervention because that stent's in the tumor grows in, closes off the stent. Lower rate of adverse events with the EUS gastrojejunectomy group. It has been used in malignant and benign obstructions of the stomach. The long-term data, the EUS group seems to have the same long-term efficacy as the surgical group. So far, the data looks really good. It requires significant technical skill. We're making a hole in 2 different lumens and connecting them together. The issue I have with it is that the adverse event rate is low, but some of those adverse events are perforations, actual holes in the stomach that can't be readily repaired. So I think this is going to be more and more mainstream in the weeks, in the years to come. And we'll probably start to see us start to turn to do this. But at least in our group here at Mount Sinai, we do a lot of duodenal stents up front, and we save this kind of procedure for those who failed duodenal stenting. But we're pretty cautious because we know that these are relatively sick patients and we don't want to take unnecessary risks, but we're capable of doing this, and we do perform this in the right patient. So how do I think about gastric outlet obstruction? Venting PEG for patients who have multifocal obstruction. So think ovarian cancer with carcinomatosis or gastric cancer with carcinomatosis, or for patients who have limited life expectancy. A venting PEG is a great option for someone who might be headed towards hospice. A gastrojejunostomy for patients with long life expectancy, indolent disease, excellent functional status. Duodenal stents for basically everybody else. The emerging data suggests the use of an EUS gastrojejunostomy as a superior alternative. Larger prospective trials are needed. So moving forward to colonic obstruction, there was a question in the audience from, could you consider a GJ tube if you're able to pass it through? So what a GJ tube is, if I scroll back. So in a patient with a duodenal obstruction here, a GJ tube is a PEG, so a tube in the stomach, and you take a little jejunal extension all the way down here, pass it through the tumor and into the small bowel. You could certainly do that. You have a venting port to vent out the stomach, and you've got a feeding port to feed them distally. That's certainly an option as well. It's really a question of whether the patient wants to eat or not. The venting part lets them take in some liquids for pleasure, and you can be fed through the jejunal extension. These jejunal extensions are finicky. They're very small. We generally don't enjoy placing these because they're kind of a nuisance to place. And even with the tumor there, they have a tendency to roll backwards and flip back into the stomach. And they also clog very easily. They're only 8 French or 12 French. So it's certainly a consideration, but generally speaking, we're more likely to go with the stent placement instead. But a GJ is certainly an option, like a GJ tube. So colonic obstruction. So here's a patient who presented to the emergency room with abdominal distension and their inability to really have a bowel movement over the previous couple of days. So on this CAT scan here, there is copious amounts of stools here seen in the transverse colon, and it's so distended, the transverse colon is dropping down into the pelvis. Right up here, you can see there's an apple core right at the splenic flexure. You can see a little tiny lumen there and the tumor along the sides. Endoscopically, you can see the tumor here, and this patient ultimately got a stent, another one of those self-expanding stents. And here's a video of a similar case. Here is the stent going across the tumor. The tumor is seen here in the distance. You can see it's a little bit bloody, and a little friability is noted from the tumor. So that's the stent catheter now having gone across, right? Even as the catheter goes across, you see some fecal material. Now we do this under X-ray and endoscopic view. Here is the stent opening up. You can see the spring opening and opening here. And then we see our catheter here. Stent is still opening. Eventually the stent springs open like you see here. And we'll go back in here for a second. And you can actually start to see this, the river of stool start to come down in a moment. And that's how you know that you've completed the procedure successfully. We tell our techs and nurses to really prep the bed because the patients usually make a horrible mess everywhere. And over the next 12 hours, the patient has numerous bowel movements as they continue to evacuate all of that retained stool. Colon stents work great. Technical success is quite high, 92%. Clinical success is over almost 90%. We'll talk about the bridge to OR group in a moment. But in patients with advanced disease, you can palliate their obstruction, or resectable disease, you can bridge them to the OR. Very low rate of death, 1%. Perforation rate, this is 4%. This data is from 2002. Every series since 2002 has the exact same numbers. Perforation rate is steady around 4, like anywhere between 3 and 5%. And there is a reobstruction rate if tumor grows back in. So, but certainly in the palliative group, these are a huge success. A question that came up about a decade ago is, okay, if patients have metastatic disease, they don't need to go to the OR anyway. You're never going to cure them with the surgery. So you place a stent and alleviate the obstruction and prevent them from ever needing to go to surgery. And that was a huge win. The surgeons didn't want to operate on those patients. They had bad outcomes anyway. And this turned out to be very successful. So now then the question came, what about a patient who comes in with a new diagnosis of colon cancer, like the patient I just showed you? They have what's ostensibly a resectable tumor. Can you potentially, now if you go to the OR with those patients, that's kind of a surgical emergency with a lot of potential complications. Is there a room for us to stent these patients, have them prep, and then go for surgery? So there's been several RCTs to answer this question. Group 1 went for an emergency stent, followed by a laparoscopic resection a week or two later. Group 2 had an emergent open surgery. Group 1 had successful decompression at 83% after stent placement, and a successful single-stage surgery, no ostomy, no repeat operation, and about 2/3 of the patients. The open surgery group, 60% ended up with a colostomy afterwards. 25% of those patients had a permanent colostomy. And about 38%, less than half, had a successful single-stage surgery. So if you compare these findings, in the stent group followed by resection, lower rates of blood loss, lower rates of anastomotic leak, 0 versus 17%, lower rates of wound infection, 17 versus 33%, lower rates of permanent stoma, 0% of the patients in the stent group had a permanent colostomy. 25% of the patients in the open surgery group had a permanent colostomy. And then a successful single-stage surgery in 2/3 of the stent patients versus 37% of the open patients. 7 RCTs have been conducted on this topic, and they all have the same conclusion. Rushing to the OR emergently in the middle of the night leads to worse outcomes. They have more complications from the surgery, and many of them end up with a permanent colostomy. And the reason is that for various reasons, they can't go back for surgery later on. They get their colostomy, they get chemo, things occur, and they just are never able to make it back to reverse that ostomy. You can imagine an enormous quality of life distinction if they have a permanent stoma versus otherwise. So some people have asked, okay, we can do a stent in the sigmoid colon. Can you do it in the proximal colon or the hepatic flexure or on the ascending colon? And yes, it is feasible, it's effective, much better outcomes when you go to the OR compared to no stent at all. Are they effective in benign strictures? So patients with diverticular disease or ischemic strictures? And the answer is yes here as well. It's ideal for this bridge to OR scenario. If you've got a benign stricture, the stent is not meant to stay there for life. You use the stent to open up the blockage, allow them to prep, and then they get to go for that same single stage, safer surgery. Are they effective in extracolonic cancer? So ovarian cancer, gastric cancer. It's technically more difficult. We're 90+% successful in colon cancer. In these extracolonic malignancies, we're maybe somewhere around 70%. It works. And as an alternative to surgery and colostomies and so on, it's preferred, but it is technically a bit more difficult. So how do we approach colonic obstruction? If their patient presents with signs and symptoms of colonic obstruction on imaging, if there's any evidence of perforation, lactic acidosis, or sepsis, those patients need to go to the OR. This suggests that obstruction's too far gone, and they're and going and doing anything short of a surgery would probably be dangerous. If there's no evidence of these, and I will tell you, I've been done this for years, we rarely see patients present with obstruction and perforation. It's exceedingly rare. So if there's no evidence of these dire signs, then they go for emergency colon stent placement. When I say emergency stent placement, I've never come in the middle of the night to do this. You can do this in the middle of the day and even on the weekend. At Sloan Kettering, when I was a fellow there, we had no ability to do these on call. So we used to just let them sit until Monday. These are not emergencies in the classical sense. These patients, when they're obstructed, that lumen has been closing slowly for months, right? If they've had colon cancer, it's taken months and years to form. So the proximal colon has been dilating over a period of months. And so their body's kind of gotten accommodated to this. That being said, coming in to do this during the next day, if we had call out a patient Friday night, we come in on Saturday during the day to do it. but you have the ability to do this semi-electively and not in the middle of the night. If stent placement is not successful, they go for surgery. If they are found to have a benign stricture or a resectable cancer, then they can get a bowel prep and a single stage surgery 5 to 7 days later. And if they have, if they are found to have metastatic disease, okay, maybe they won't need surgery at all. They could just go on to chemo, and they can get chemo literally the next week. You don't have to have a delay in treatment because they've had surgery. So of all those stents, colon stent still remains a win. We stent pretty much all of those patients. We've gotten a lot more nuanced and a lot more thoughtful about how we approach the duodenal stents and the esophageal stents. Switching gears, the second topic I wanted to talk about was pancreatic fluid collections and infected necrosis. So this is a necrotizing pancreatitis. So most patients with pancreatitis have interstitial pancreatitis. That's just inflammation of the pancreas. Necrotizing pancreatitis occurs in somewhere around like 10% of patients with pancreatitis. And that's where pancreatic parenchyma essentially dies. And anybody with pancreatitis or even necrotizing pancreatitis, they might develop a pseudocyst or walled off necrosis. A pseudocyst is what you may have recalled from years ago. It's essentially a blister of the pancreas. If you think of pancreatitis as a burn, if you've ever burned your hand, you might get a blister. Pancreatitis is a burn, and as all of that inflammatory dead tissue coalesces together, you get blisters. So in this CAT scan here, these are blisters on the pancreas. It is the result of from an acute fluid collection. It's fully encapsulated. There's a wall. You can see a discrete wall here. And the contents are homogeneous. You can see here, it's just an even gray. It's just simple fluid, like you would have in a blister on your hand from a burn. Walled off necrosis results from necrotizing pancreatitis. You can see here quickly that this looks very different than this. You've got an air fluid level, and you've got these little sort of chunky areas here. It looks almost like stool. This is solid debris, necrotic debris from the death of either pancreatic tissue or peripancreatic tissue. So it does have a great wall here. It's fully encapsulated. The contents are very heterogeneous, which suggests debris. So when do we need to intervene on these patients? The classic teaching is if you had a pseudocyst or collection of more than 6 centimeters for more than 6 weeks, they all need to be drained or treated. We've learned a lot over the years. The only ones that need to be drained if they have signs of infection, if that collection is obstructing the duodenum or the stomach, if the collection is actually sitting on the pancreas and causing recurrent pancreatitis, it's causing biliary obstruction or causing pain, those patients need to be drained. Everybody else should be left alone. I've had patients with 14 centimeter pseudocysts, which is pretty big, without any symptoms at all. So we left them be. I've had other patients with a 3 centimeter pseudocyst, but because of its location was causing them recurrent pancreatitis, that patient needed an intervention. So patients without symptoms should be left alone. In necrotizing pancreatitis, it gets a little bit more complicated. Some of these patients with necrotizing pancreatitis are in the hospital for weeks, maybe even months. If they have any sort of infection, bacteremia or so on, then they would need to be drained. There is a great term called persistent unwellness, which is kind of what it sounds, or to be more colloquial about it, you walk into a patient's room and they just look, they look ill, right? Low-grade temps, persistently tachycardic, just the malaise and fatigue and lethargy, the smoldering abdominal pain, the sort of unwell feeling about them. You all know who they are when you see them. Or patients with persistent organ failure over many weeks. Those are all indications for necrotic collections, to drain necrotic collections. Before we get into some of the procedures that are there, there's one surgical approach to be aware of. So in this cross-sectional axial view, here's the pancreas here. This brown area is this infected necrosis. One of the minimally invasive approaches that's been developed over the years is that IR could put a drain right through the lateral abdomen, right into this collection in the retroperitoneum. As that tract matures, surgeons can then go and basically make an incision here, put a retractor in there, and follow this catheter into the retroperitoneum and then use their surgical tools to debride out that area. This spares them the alternative of a huge laparotomy and a major surgery. So in the Netherlands, they have an incredible pancreatitis cooperative, the Dutch pancreatitis group. And it's pretty fascinating. If you get into any of the Dutch hospitals with pancreatitis, you basically call 1-800-pancreatitis, and you get randomized into one of many trials. And they've generated a remarkable amount of data that really has shaped how we approach pancreatitis today. So one of the trials they did is in these patients with necrotizing pancreatitis and necrotic collections, the standard of care for many years was open surgery, big laparotomy, and then debride everything out, and then close them up. And so now they said, can we do this minimally invasive procedure that I showed you earlier, a VARD, and randomize that against open necrosectomy? So the step-up group, 43 patients had drains, like I showed you placed, that retroperitoneal VARD, where they cleaned out things from the retroperitoneum, and then additional procedures in 14 patients as needed. They compared that to the group who got an open necrosectomy, the laparotomy that I told you about. And then the 42% of those patients had additional surgeries. So the first number to draw your attention to is major complications or death. These numbers are astounding. In the open group, 69% of patients with major complications or death. The VARD group was better, but it's still pretty grim, 40% with major complications or death. So the first thing is this is a high mortality disease. And so then the question is, can we do better than this? So then the endoscopic approaches were developed. This is the endoscopic drainage of a pseudocyst. So here is that cyst, that fluid that I told you about. And you can see here, we've made a hole in the stomach wall. And this is a balloon here that we're going to stretch open that wall. And on the other side of this wall is that pseudocyst. And you can see it's like kind of popping a zit. As we pull this out, it's just a river of pus coming out. Kind of gross, but immensely satisfying. The patients do great after this. And you can see here, you can see our tunnel right into the pseudocyst. And we eventually place some stents in there. In a group with walled off necrosis, it's not just fluid, it's dead tissue. So here is this collection here with, you can see some debris and solid stuff in here. We're opening a stent, as I'd shown you already. This is that lamb stent. And as we pull it up to the wall, and now it's deployed. Now we can take our scope actually and go inside that collection. And then when we go inside, you can actually see all this dead tissue in here. This is all dead pancreas, dead peripancreatic tissues. And over a period of multiple weeks, and you can see here all this dead tissue, we use different endoscopic tools to literally grab and pull that stuff out. When surgeons are doing necrosectomies, this is what they're doing. They're grabbing dead tissue and pulling it out. They're debriding the wound. This is effectively what we're doing. Here we're pulling out a big chunk of sort of dead tissue out of that stent. And you can see here, there's a large specimen left in the end there. When we go back in, you can see it doesn't look amazing, but it looks really good in the sense that there's no more dead tissue. This is all pink, healthy granulation tissue everywhere. Once you've gotten rid of the infected dead stuff, this collection closes down. So next RCT trial, 1-800-pancreatitis, randomized to endoscopic approaches versus that minimally invasive group we talked about. In the surgical step-up group, they got drains followed by VARD, that retroperitoneal dissection, and additional surgery in limited number. The endoscopic group, they got the cyst enterostomy that I showed you, that stent placement, followed by endoscopic necrosectomy, where they went in and cleaned out that stuff with the scope, and then 40% with additional procedures. Major complications or death, still highly morbid disease set, 40%. So when we see our patients now, we tell them 40%, either death or major cardiovascular or pulmonary complications. But the difference here is pancreatic fistulas, only 5% in the endoscopic group versus 30%. These are fistulas out to the skin where the drain was. So you may have pancreatic juices leaking against your skin, which is a sort of a painful, morbid thing to suffer from. Length of stay, even in the endoscopic group, length of stay of 35 days compared to 65 in the surgical group. So no matter what, patients are there for a long time. In our experience at Sinai, very similar. We've had patients here as short as 2 weeks, as long as 3 or 4 months. And these are statistically significant. Does it work? This was a patient who's 24 years old. They had an ERCP upstate somewhere for CBD stones, and they ended up getting terrible pancreatitis. They were in an ICU upstate. They were persistently febrile. It's 24. Was on dialysis eventually due to his critical illness, and got transferred here to Mount Sinai. When we first met him, this is his coronal CT. You can see huge amounts of inflammation, an enormous collection in the middle of his abdomen, ascites and fluid everywhere, essentially. So all this is just inflammation and fluid. This is necrotic debris over here and more fluid and necrotic debris over here. We did his procedure twice a week for almost 6 weeks. And this was his last scan when he was here. And you can see all of that fluid is gone. These are our stents. All of his bowels are now open, a little tiny bit of inflammatory fluid on the side. Off dialysis by week 2, stopped having fevers by week 3. He walked out of the hospital. No feeding tube, no anything at all. He did fantastic. So it's an incredibly effective treatment option to offer patients. It does require sort of multidisciplinary assessment and management. We work with our surgeons. Some patients benefit from surgery. We work with interventional radiology. Some patients benefit from drains. If anything, we've learned over the years, every patient is slightly different, and you have to approach them all differently with your team. And that's what we've done here. The last group I wanted to tell you about, taking this idea of using EUS to drain things and taking it a little bit further. So the video I showed you earlier was talking about EUS guided gallbladder drainage. So here's a 76-year-old male, COPD, pulmonary hypertension, rapid AFib, decompensated heart failure, hypoxemic respiratory failure. Develops acalculous cholecystitis. You've all seen these patients in your ICUs. Not a surgical candidate. So we were asked to do gallbladder drainage. So we're placing one of these Axios stents that we've seen already. Here's a stent opening up here. And then as we come out into the stomach, you'll see here this heavy sort of nasty sludge coming out. And as we sort of stretch this open, and then you start to see some of the really sort of crystalline debris and infected sort of junk coming out of the gallbladder. And he did, from a gallbladder standpoint, did perfectly well and defervesced quite nicely. So there's 3 ways to approach dealing with cholecystitis in patients who are not operative candidates. There's a percutaneous gallbladder drainage, a percutaneous cholecystostomy tube, or perc chole. That's just a drain through the skin, right up into the gallbladder. There is the endoscopic transpapillary gallbladder drainage. That's a stent through the papilla into the cystic duct, into the gallbladder. Remember, in cholecystitis, the mechanism is occlusion of the cystic duct. And so if you're able to drain the gallbladder somehow, so if we take a stent through that occlusion and drain it in here, all that pus comes out. And there is this EUS gallbladder group that I already showed you. So in a meta-analysis of 400 patients, the technical and clinical success of the EUS group is very high, 8% adverse event rate. There are 2 RCTs now where they randomize patients to this EUS gallbladder drainage versus a perc chole. The technical and clinical success was the same in both groups, and the 30-day mortality, 10%, which is high, but remember, these are very sick patients. That's why they're going these less invasive routes than a surgery. A much higher rate of reintervention in the perc drain group. 30% of those patients needed to have a repeat intervention. And 3% of the patients in the EUS group needed reintervention. If you've ever seen patients with these drains, they're uncomfortable, they clog, they kink, they fall out. 30-day adverse event rate, much higher for the perc chole group, as I had mentioned. Migrations, kinks, and clogging, much lower for the EUS group. And a higher 1-year adverse event rate in the perc chole group, 78% 1-year adverse event rate versus 25%. So, and these are now 2 RCTs to show the real superiority of the EUS guided group compared to perc chole. So a lot of nuance here. It's not EUS for everybody. you consider the percutaneous cholecystostomy if you're unable to tolerate sedation, right? At the end of the day, the endoscopic approach requires pretty deep sedation. And if the patient is too tenuous from a pulmonary standpoint, then they're going to need a perc chole because you can do that with a little bit of Versed. The EUS guided group, all right, that's a stent from the papilla all the way into the gallbladder. This is great for someone who's got gallstones or has a choledocholithiasis, CBD stones. You can clear the stones, put a stent in the gallbladder all in one shot. If the patient's ultimately going to undergo a cholecystectomy, this is a good procedure. If they have ascites, I think one of the questions in the chat was, if they have ascites, would you do the EUS procedure? Probably not. That the ascites can kind of get in the way a little bit and may prevent the gallbladder, the duodenum from sticking together. If the patient has any sort of coagulopathy, then this ERCP procedure is great. EUS gallbladder drainage, anybody with severe cystic duct obstruction, or maybe they have duodenal or ampullary obstruction with pancreas cancer. So again, this sort of drainage of the gallbladder is off-label, but it's gotten a lot of traction. And so we really go through a multidisciplinary discussion with IR and with surgery. And you really need to think about the long-term sequelae. Are they super sick today? But are they going to go for a cholecystectomy in 3 months? Then maybe putting a hole through the duodenum into the gallbladder isn't the best way to do this. Or are they pretty chronically ill and they're probably never going to go to the OR? That's where the EUS gallbladder drainage really may make a lot of sense. Other sort of drainages here is that this is a 44-year-old female. She's an ultrasound tech and had diverticulitis 2 weeks prior. She kept having right lower quadrant pain, so she kept scanning herself with the ultrasound machine, and she found an abscess. I'm like, well, that's convenient. You figured it out. Didn't want a CT drainage. She was an ultrasound tech. That's the last thing she wanted to do is get radiation. So we can see the extrinsic, this is the rectum here, and you can see a big bulge from that. And again, same sort of technique where we place one of these axiostents, and we see this flow of pus coming out as we do this procedure. And again, immensely disgusting and really satisfying. And we take the stents out we can usually take them out a couple weeks later. She waited a little bit longer, but we can pull the stent out. And then we can tip our scope right in here and you can see healthy granulation tissue. That all fills in. Now that the stent is gone, that'll just close up within a week. It's pretty fascinating. So some final thoughts here. We have an ever-expanding arsenal of endoscopic devices and techniques. We really need multidisciplinary evaluation for these complex interventions. You can see we're starting to cross over into some surgical style intervention. And so we really do work closely with our surgical and interventional radiology colleagues. Stent placement for malignant GI obstruction, patient selection is critical. Not everybody needs a stent, but those who do need one, they do really, really well when we choose the patients carefully. Pancreatic fluid collections, endoscopic management is now the first line approach here. Surgeons have been happy to throw us these patients. This is a horrible surgery, horrible outcomes for patients, and they've been more than excited to sort of hand it over for endoscopic treatment. Abdominal abscesses, cholecystitis, a liver abscess, pelvic abscesses, they can all be treated with endoscopic drainage. Really advanced endoscopies providing novel approaches to all sorts of diseases. I showed you a few of them today. We really have a firm commitment to clinically relevant patient-centered outcomes. It's not enough to say that you did it. You really need to demonstrate this is a better approach and better for patients. And I'm hoping that we'll see ourselves move more and more towards multi-center prospective trials, focused on disease management rather than technical success. That's really how we're going to move the needle forward in this field. Last thing is, anything is possible. We really like to be creative. We like to think out of the box, and we've really pushed ourselves to do so in the recent years. So we tell everybody, just ask. And if we think it's feasible, we'll give it a shot. Thank you.
Thank you so much, Dr. Nagula. I think Dr. Raghavan, you unmuted yourself, but I just wanted to say thank you for this wonderful overview for us internal medicine folks, just to dive into the great world of GI and endoscopy. So I think, Dr. Raghavan, you were going to open it up to questions and comments. So I know Jenna has been asking a ton of wonderful questions in the chat, so thank you, Jenna. But any other questions for Dr. Nagula?
I have a question, if that's okay. Thank you, Dr. Nagula, for a really thorough overview of all the advanced procedures that you specialize in. I have a question in pertaining to patients with, a history of bariatric surgery, like Roux-en-Y procedures. I presume that, some of them may be for surgical candidates, and although you do have like a multidisciplinary approach, how would you, tackle some of these drainages, given they have like kind of complex anatomy?
It's funny, before I jumped on this call, I was talking to a patient with this exact issue. They had CBD stones after Roux-en-Y bypass. One of the things we can do, so as you know, with Roux-en-Y bypass anatomy, they have their gastric pouch and this long limb of jejunum. Their gastric remnant is over here. We actually will place a stent connecting the gastric remnant and the gastric pouch, bringing them together. Now we can scope native anatomy. And that allows us access to the pancreas, allows us access to the bile duct. This patient had a little bit of an urgent situation with their stones. So I was trying to explain this over the phone, which is enormously complicated to do without a picture. But essentially, you reverse the bypass. We are going to make a connection between the gastric pouch and the gastric remnant. That gives us full access. And then we will remove that connection and actually suture that hole closed. And so all in all, it ends up being a much simpler and easier thing to do than going to the OR.
Thank you. And you would suture it right away, or you would have to go back?
Usually it's in multiple phases. We create the fistula first, and then we go in and do the ERCP a couple weeks later, and then we close the fistula after that. Any other questions?
Thank you, Grace.
I wanted to ask just if that's all right. Just because a lot of these procedures are kind of like frontiers in some way for trainees, which often obviously I'm thinking about, how do they, because there's that level of ingenuity and creativity that kind of goes into thinking about these. So how would you suggest the trainees kind of approach this personalized kind of view of heading towards specific procedures catered towards exactly what they may, like what the patient may need? How would you kind of suggest that they, because this wouldn't be like guideline based, how would you suggest that they kind of think about this?
Yeah, it's true. I mean, the guidelines are starting to catch up a little bit now. I think what it comes down to is in patients with complex GI diseases where we've gotten to be pretty good at anatomic problems. So most of the things I've described are anatomic: removal of lesions, bariatric surgery, so closing down sort of lumens or connecting to lumens or draining abscesses. These are all anatomic things. So when it feels like conventional GI, conventional medicine isn't really addressing an anatomic problem, that's where sort of asking the question of, one of the interventional folks around, hey, is there something different we can do or approach here? And so I think, at least in terms of them thinking about patients, that's what I'd sort of advocate for. If something isn't making sense or something that seems really invasive, we've come around. We've recommended surgery for a number of people, saying the most invasive thing is the best thing for the patient. But I think it just comes down to those conversations and asking. But nowadays, a lot of the guidelines from the GI societies are really including some of these more cutting edge techniques, because the core techniques are the same, and now we're just applying them to different things. And so we're starting to see that in more and more of our documents lately.
I think fair enough. Thank you. And I also saw that Dr. Risk had put in the chat a team-based approach, great for collaborative evaluations. And I totally agree. I mean, I think because sometimes as the medicine team, you can be conflicted about who to call, maybe who to call first, but having that be an interdisciplinary conversation is great.
Yeah, I think it's great. And every institution is a little bit different because people need to be familiar and sort of aware. I've been talking about colon stents for 15 years. And when I first started talking about it, the surgeons didn't want to give up those surgical cases. I mean, at the end of the day, it was also their own surgical volume that they were sacrificing. And it was really just beating the drum of like outcomes, 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 that everyone started to change the way they think. So I think it is important for us to sort of just keep that in mind. You're right. It's many of the GI folks within our system will call us, or they'll call Ed and Tina over at MSW or MSM, and then we're able to sort of launch the conversation from there. But sometimes we just don't hear about it because people don't ask us. Sometimes we find the GI Council never really called us because they didn't know to do so. That's on us to continue to educate our own teams.
Thank you.
Thank you so much. I think we have about 5 minutes left. So any closing remarks, any last minute questions for Dr. Nagula?
For me, what's exciting about this is really seeing the dynamic change in the literature and moving towards outcomes. There's a whole lot in the advanced endoscopy world of look what I can do, as any sort of procedural specialty can be. And for me, it's nice to see the field slightly changing. That's part of why our group is a little bit on the cautious side, because it's just not good enough to say that you can do it. It really needs to be helpful.
Great.
Well, reach out to me at any time if you have any questions.
Thank you so much, Dr. Nagula, for this wonderful talk. Thank you everyone for coming in person and joining us on Zoom. We'll see you next week for our grand rounds. Thank you so much. Bye, everyone.